Let's talk about mood disorders. Mood disorders would be major depression and mania. Major depression is characterized by feelings of pessimism, worry, intense sadness, and loss of concentration and slowing of mental processes. Depression is not just being bummed. It's an overwhelming feeling, and it's common. 1 out of 5 of our clients in the hospitals have symptoms of depression. Primary care providers do not diagnose depression in 50% of their clients. 1 out of every 8 adults suffers from depression. So in this room, very likely 3 to 5 people have depression. 71% are women. Lifetime risk for depression, 7 to 12% men, 20 to 30% in women. And an estimated 15% of severely depressed people will successfully commit suicide. Mania is characterized by feelings of intense elation, insomnia, hyperactivity, and irritability. So, we're caring for a 48-year-old female. She has symptoms of generalized aches and pains with extreme fatigue. She's married, 2 children. The youngest just left for college in the fall. She admits that she's lost about 15 pounds in the last 2 months as a result of just no appetite. She has trouble getting to work every day and just received a disciplinary notice because decreased attendance. So there's a lot of symptoms of depression in there. So what are some of the criteria from DSM-4? Depressed mood, cheerfulness, weight change, appetite change, sudden or sleep pattern changes. And all those changes could be up, could be down. Some people, when they get depressed, they eat a lot. Some people have no appetite. Some sleep a lot, some don't sleep. Fatigue, no motivation. They feel worthless. Psychomotor changes, the lack of coordination. Confused thinking, can't concentrate. Indecisiveness. Diminished interest in daily activities and inability to experience pleasure. If you have or somebody has some or many of those symptoms, in all likelihood, we're looking at depression. Nursing diagnoses, very common, similar to the anxiety ones. Impaired adjustment, ineffective coping, dysfunctional grieving. Now, grief in and of itself is not depression. We all experience grief at a loss. It's when the grief overwhelms us and overtakes our lives and doesn't allow for us to move beyond it or move with it. That's when it becomes a problem. So altered nutrition, either too much, too little, powerlessness, self-care deficit, sexual dysfunction. All of these nursing diagnoses should be, when you see depression on your patient's list, these should pop into your head right away as potential nursing diagnoses that you have to address. They're treated with antidepressants. And there's 3 categories that are most common: the MAOIs, the Tricyclics, and the SSRIs, SSNRIs. And we'll talk about each of those individually. Now, what about treating depression in children? Should we? Can we? Is it safe? Children experience depression just like everybody else. They experience anxiety. So, can antidepressants be safely used in children? We'll talk about that in class. A diagram of how various antidepressants work within the cells. Now, antidepressants, the SSRIs, the selective serotonin reuptake inhibitors. We talked about these for anxiety also. So we have Celexa or citalopram, fluoxetine, Prozac, sertraline is Zoloft, and paroxetine is Paxil. They inhibit the reuptake of serotonin at the nerve endings. Remember, you got the nerve endings, serotonin's floating between the nerves, and these keep that serotonin floating. So there's apparently more serotonin in the body. There isn't any more. It's just available more. It has an antidepressant effect. It decreases anxiety. It can alter people's eating disorders. It's also a smoking deterrent. If we're looking at selective serotonin and norepinephrine reuptake inhibitors, that's the SSNRI. Cymbalta is the classic SSNRI, and it inhibits the reuptake of both serotonin and norepinephrine. So it treats depression, but it also treats neuropathic pain, anxiety, and just generalized pain. We always worry about side effects though, right? Side effects can make people stop taking the medication. Side effects can make people sicker. So we worry about side effects. Neuroleptic malignant syndrome, suicidal thoughts, dizziness, drowsiness, insomnia, and apathy. Why would people have suicidal thoughts if they're taking an antidepressant? Now remember, depression can cause altered thinking as well as lack of motivation and confused thinking, inability to concentrate. If you take a medication that improves that, but you still feel depressed, now you might actually start thinking about other ways of solving that depression permanently. So that's why we need to watch out for that. Could have chest pain, palpitations, dry mouth, diarrhea, nausea, anxiety, anorexia. The whole list there. SSNRIs, hepatotoxicity, and Stevens-Johnson syndrome. That one that came back from all the antibiotics. Now these are superior to tricyclic antidepressants and MAOIs in their side effect profiles. These are the first line agents for depression. Doctors will go to these two categories first. There's not much effect on norepinephrine or dopamine reuptake. Some for the norepinephrine in the SSNRIs, but not a lot. Many fewer side effects, fewer drug-drug or drug-food interactions. An advantage over the tricyclics and MAOIs, little or no effect on the cardiovascular system with very little anticholinergic effect. Sertraline is the most selectively inhibits the serotonin exclusively opposed to norepinephrine uptake. Fluoxetine is the least selective. So if we're allowing more serotonin to stay in the synapses, there is a chance of serotonin syndrome. That's when there's involuntary muscle twitches, muscle spasms, hyperthermia, tachycardia, heart rate well over 100, agitation, delirium, coma, and seizures. But fatigue, sexual dysfunction, and weight gain are the most common and bothersome side effects. SSRIs and SSNRIs also depress REM sleep. They're sometimes used for eating disorders because of for people who are, by eating disorder we mean not eating, because the side effect of weight gain is relatively common. You should not take with tricyclics or MAO inhibitors. Symptoms of overdose, tachycardia, arrhythmia, seizure activity. In other words, almost the serotonin syndrome, but caused from overdose. Smoking enhances the metabolism of Prozac. So you may need to increase the Prozac dose if a person smokes. We're going to assess for fatigue, sexual dysfunction, and weight gain, as these are the most common, and these are the reasons people will stop taking these medications. It also depresses REM sleep. Fewer dreams is less restful and restorative sleep. Now, tricyclics have been around for more than 40 years. By tricyclics, we're looking at Elavil or amitriptyline, doxepin, imipramine, and nortriptyline. Those are the generics. These block the reuptake of neurotransmitters, the serotonin and norepinephrine. They cause an accumulation at the nerve endings. It also blocks the muscarinic and histaminergic, adrenergic, and dopaminergic, and serotonergic receptors. So it has a lot of effects. These have largely been replaced by the SSRIs in the 80s when Prozac was first developed. These are actually considered now second-line treatments for people who fail SSRIs. It does work used as an adjunct with newer antidepressants. So it's used for actually, for an antidepressant. Bedwetting in children, that's only imipramine though. And neurogenic pain, or pain that is generated within the nerves. Side effects related to the blocking actions? Well, because it blocks a number of those chemicals. So when it blocks dopamine, you're going to develop movement disorders, similar to Parkinson's. When it blocks acetylcholine, you're going to have a dry mouth and urinary retention. Blocking histamine, drowsy and sedation, and weight gain. The serotonin, sexual dysfunction, decreased seizure threshold, and adrenergic orthostatic hypotension. That's why tricyclics are no longer first-line treatment. All of those side effects are seen. The side effects and the greatest risk of all is suicidal thoughts. That is the key risk of tricyclics. Drowsiness, fatigue, sedation, hallucinations, and arrhythmias are common. Constipation, dry mouth, weight gain, those all happen. But you must be aware that suicidal thoughts are the key risk. Overdose is lethal. 70 to 80% of the people die before reaching the hospital. It's the CNS and cardiovascular system that is most affected. Death results from seizures or dysrhythmias. There is no specific antidote. You can decrease absorption with activated charcoal if you get it in the person quick enough. You can alkalize the urine to help increase elimination. You need to manage the seizures and dysrhythmias with other chemicals to control that. In essence, you are going to support the person as their body metabolizes the tricyclics. Otherwise, there's nothing else you can do. Activated charcoal, you have to get that within their body within 2 to 4 hours. The earlier, the better. Otherwise, it doesn't do any good. So nursing considerations. As always, we're going to assess mental status and changes before starting and then while administering the medication. We're going to look for fatigue and sexual dysfunction, weight gain. We're going to look for, monitor their appetite. Look for nutritional intake. We need to monitor blood pressure and pulse before and during therapy to observe for cardiac dysrhythmias. Cardiac dysrhythmia, remember that is a bad rhythm, bad rhythmia, rhythm. So it's a bad heart rhythm, and a bad heart rhythm will change their heart rate, so it will change their pulse. It will also affect their blood pressure. It can either make it go very high or very low. So we need to monitor pulse and blood pressure before you give it and while we're giving it. Labs can complete CBC, complete blood count, liver functions, and glucose. We'll watch. Toxicity, again, usually fatal 80% of the time if there's an overdose. We treat symptomatically. We try to support while the person tries to survive. We're going to be watching again for arrhythmias, again, no rhythm, and seizures. They may experience hallucinations and profound fevers.